I want to thank everybody for being here, and what I want to talk about is, since the rules are not out, we don't know, I want to talk about how we've looked at making the case for a renal ACO and how we've looked at several of the factors that are key components that will be required of accountable care organizations. And so when we look at one of the key requirements, it's how do you attribute patients? And so we've looked at our patient population. As you know, this is actually the per patient per month cost of patients in late stage CKD, transition to dialysis, and then further on in their late incident and prevalent periods with ESRD. And so it's very, very clear that when you look at the cost data, we've got to recognize that patients with this transitional period have their highest costs right around the time that they initiate dialysis. It's hospitalizations, it's very high mortality that you know of. And that begs the question that you've got to include some degree of late-stage CKD preparation and care as part of this model. So when we've looked at attributing patients, we've looked at identifying patients with claims and ICD-9 data for late-stage CKD, as well as recognizing that through our use of the estimated GFR, we can identify this population fairly clearly. Now, one of the issues is much of that population doesn't progress, and so you've got to deal with how do you further stratify and try to identify those that are progressing and those aren't. And finally, then dividing up the end-stage renal disease population into two primary components. Those components being the incident population needing specific attention and the prevalent population needing differential hospitalization avoidance, congestive heart failure avoidance with urgent treatments, and other additional costs. So from an attribution standpoint, as we've gotten together with those of us that are members of the RPA, with the dialysis organizations, large and small, we've realized that we really need to take this whole continuum of care and include it in this area. So when we look at this concept of creating this home, there's a lot of rationale that we have provided to the government that says renal disease care already has many components of coordination and care already either partially in place or fully in place. And so if you look at these, we recognize that in CKD and ESRD, we've got this high degree of intensity of contact with patients, both in the practice and with the dialysis programs and facilities, where we're seeing patients on a much higher level than many other areas of chronic disease care. We have the bundled payment system, which has already created models that are coming into play for renal disease that recognize that we have moved along this risk stratum from fee-for-service towards more capitated and bundled care in a value-based performance system, which you all have heard quite a bit about over the last year. Partial capitation has been demonstrated. There have been multiple demonstrations now. They've carved out several areas that would be components of ACOs and have shown gains that I think Jess had mentioned previously. So there is some experience in care coordination that exists today. And then finally, on the HIT side, we've been reporting performance measures longer than most of the areas of medicine. So we've got analytics that are vitally important here. We've got an infrastructure for measuring and reporting analytics. On the end-stage renal disease side, we have the USRDS that has provided a wealth of data on practice patterns. And there is a realization that on a subspecialty basis, there is a progression towards utilizing technology and adopting that technology somewhat more aggressively than some of the other subspecialties. So we've gone to CMS and the White House and the legislatures, and we've said we believe there's a case that renal disease should be treated specially here. And in fact, it's been treated specially for 30 plus years now. And so that's part of where the rationale is for these components. When you begin to look at how we're suited for this, you can run down the access to patients that exist, the collaboration that already exists. The conditions for coverage require an interdisciplinary team care plan. That kind of care planning is relatively unique among subspecialty care and gives us an extensive ability to already have created models in which that exists, predominantly in the end-stage renal disease population. We've talked about many of these others, but when you begin to look at how the program for renal disease care has scaled across the country, you've gone from what previously was a 100% mortality condition to a condition that doesn't have a mortality rate that we're necessarily happy with today, but in fact it is, care for these conditions is available in every part of the country, whether it's rural, urban, in all of those settings. And so we have already got a scaled model that exists today that is part of the ESRD program that we believe actually would allow us to get to a coordinated accountable care model much quicker than many other areas of medicine. This is a slide that simply wants to say this is really what's happening. You're increasing risk along the payment schedule. CMS has been very clear in articulating that they want to move away from the fee-for-service side on the left. They want to move towards the right, not necessarily, you know, everything being fully capitated, but recognizing that in many cases this concept of value-based purchasing is going to add performance payment as opposed to volume-based payments. And so when we look at this, it is taking the distinctions of what we learned when we had insurance risk models from the global cap models and the managed care model, in which you were taking risk on patients getting a disease and moving that to a performance risk model, in which the performance risk is based on, we know you have the disease, you're attributing in patients that we know a priori already have this disorder, and in fact, can we improve areas of care that improve that, and in doing that, provide a way so that we move past shared savings into more of these bundled global payments for these types of diseases. So when we look at our patient population, we're looking at a lot of unique networks that already exist, and the recognition that we've tried to make is that a general ACO would not be a place in which renal disease patients would get the degree of attention and the focus that's necessary, and that the existing networks that exist between nephrology practices, nephrology organizations, dialysis providers, and vascular access centers, vascular surgeons, interventional nephrologists, is a model that actually makes more sense for this particular population than throwing them into the general geographic-based model. And that's one of the things that we've been testing with our conversations with CMS. Now, there are several avenues in which this could in fact take place. It can take place through the primary rule that comes out for ACOs sometime in the next couple of months. It could take place through an expanded pilot program that may run through what's called the Innovation Center that CMS has presented. And the third place, which to me would be sort of the plan C, would be recognizing that if in fact general ACOs must attribute these kinds of patients in there, they may well want to carve those out so that a group that actually understands how to care for this population and reduce these costs better may be able to include that. And so finally, if you say, what are the ultimate goals? This is a slide that came from a group that actually looked at the HIT requirements for ACOs, recognizing that as you start, you begin with standard sort of early maturity case management tools. What you're moving towards the right end is actually a much more sophisticated real-time interaction of sharing information, making that available to providers, and the group of providers where it isn't just one-by-one care by a physician and a patient, but in fact it is taking that care and extending it into a true structured care process. So with that, I'll sort of stop, and I think Ruben's going to speak to some of the issues specifically that we've talked about at the RPA and related to nephrologists.